Good morning. I'm delighted to be here with you to be speaking on GLP-2 and beyond in chronic intestinal failure. And therefore, I'm going to speak both about the present and the future state. I would have much rather been with you in person, but this is unfortunately the world we're in right now. So thank you to Oley for allowing me to be here today. Here are my disclosures. As you can see, there are now many different pharmaceutical companies interested in this area. That's a good thing for the field, a good thing for patients. And because of my interest, I'm, of course, widely conflicted, and therefore I could argue I'm not conflicted at all. Perhaps the most important disclosure is the fact that I'm a surgeon speaking to you about medication, so take that as you will. First, some definitions. Intestinal failure is defined as the reduction of gut function below the minimum necessary for the absorption of macronutrients and/or water and electrolytes, such that intravenous supplementation is required to maintain health and/or growth. Short bowel syndrome, on the other hand, refers to loss of significant length of bowel due to disease or surgical resection. Just to emphasize, intestinal failure can be due to short bowel syndrome, which is the majority of cases, but it can equally be due to functional disease, such as pseudo-obstruction, dysmotility syndromes, Hirschsprung's disease, etc. Short bowel syndrome leads to intestinal failure in about 70% or so of cases. I like this graphic, and I want to walk through it with you. If you look at the lower panels, the illustration of the shortened intestine will go from left to right here. At the extreme left of this panel is what we call group 3 anatomy. These are patients who have some jejunum, the first part of the small bowel. They have some ileum, the last part of the small bowel. And importantly, they have the entire colon in continuity. This is called group 3 anatomy. And these are the most favorable prognostic groups. These patients should and usually tend to do well. Moving to the right, in contrast, at the extreme end are the patients in group 1 who have an end jejunostomy. They have the first part of the small bowel, the jejunum, usually nothing beyond, and that bowel ends in a stoma. These patients are sometimes the most challenging to deal with, and group 2 falls somewhere between the two. This might seem like I'm stating the obvious, and sometimes the obvious needs to be stated. Parenteral nutrition should be considered the primary treatment for patients with short bowel syndrome-related intestinal failure. And the reason to state that is just to emphasize that no new drug, GLP-2 and beyond, has actually replaced parenteral nutrition yet as the primary treatment. So GLP-2 is indicated only for patients who are requiring parenteral nutrition due to short bowel syndrome-related intestinal failure. And by contrast, parenteral nutrition is the first-line treatment for these patients. I like this slide very much, shared with me by Professor Palle Jeppesen from Denmark, who's done a lot of work in this area. And what I'd like you to do is to walk with me from below up. So the first line treatments for patients with short bowel syndrome-related intestinal failure is dietary advice. Pay attention to what the patient's eating and drinking, and just as important perhaps is how patients are eating and drinking. And then I'm sure you will hear about oral rehydration solutions and avoidance of plain water and juice, etc. And then we come to what we regard as standard of care first-line drugs. These are the antidiarrheals, the anti-secretory agents. And then finally, in line with what we call hormonal hyperadaptation, comes the era of intestinal growth factors. And I will say this is an older slide, we would like to go away from the idea of growth factors, because these are intestinal peptides, smaller protein molecules that are not all growth factors. Growth factors suggest something else, and these have different effects on the intestine. So we should be talking more in terms of gastrointestinal peptides or peptide hormones rather than growth factors. But you can get an idea of a stepwise approach to managing patients with intestinal failure, starting from the simplest, low-risk interventions all the way to the more cutting-edge interventions, into which category GLP-2 falls. So again, to state the obvious, conventional pharmacological approaches, typically anti-motility and anti-secretory medications, antidiarrheals, acid suppression, etc., should be used aggressively as first-line agents in the management of short bowel syndrome-related diarrhea or excessive stoma losses. Stated another way, GLP-2 is not simply one more antidiarrheal, even if that is the beneficial effect we're often targeting. There are other simpler and safer drugs that should be tried first, with GLP-2 being, in a sense, layered on top of that if additional help is required. So the era of GLP-2 really started with this gentleman here, Dan Drucker, who is an endocrinologist in Canada. And he did some seminal work showing the effects of GLP-2 on nutrient absorption. And the graphic on the right side shows this effect dramatically. In animals treated with GLP-2, the villi, which are the finger-like projections on the intestine, became dramatically longer and taller. And it is this effect on the villi that appears to translate into beneficial effects for patients. So what has been the experience with Tendulotide? This slide summarizes the results of the phase 3 randomized control trial, the STEPS trial, that ultimately led to approval of Tendulotide in short bowel syndrome-related intestinal failure. I'll say this only once, Tendulotide, maybe I'll say it more than once. Tendulotide is the only GLP-2 analog that is currently approved by the FDA, sold in the United States under the brand name Gattex. I will avoid using that name if I can. But when I speak about Tendulotide, I'm referring to Gattex. That is available on prescription in the US. You have to go through some steps before you can get it, but that's the approved drug. So what was the data that led to the FDA approving this? The primary endpoint on this study is shown in the darker panel on the left. And what we were looking for is to see the percentage of patients who got GLP-2 who achieved at least a 20% reduction in their TPN volume at weeks 20 and 24 into the study. And what you can see there is just shy of 2/3 of patients who received Tendulotide met that primary endpoint, i.e., they had at least a 20% reduction in TPN volume. I'm going to come back to the rest of that dark panel in a second, but if you look at the graph on the right side of the slide, you can see the black bars show that over time, there was a continued increase in the benefit. Patients decreased their TPN volume, and that decrease gradually increased over time, as shown by the black bars. But there's something else that's very interesting on this slide, and that is the effect seen in the placebo group. Just to clarify for people who are not familiar with this term, placebo refers to the group of patients who just got saline injection just to make sure that nobody was really somehow influencing the results. So the group of patients who got placebo injections also had some response during the period of the trial. About 1/3 of patients, 30% of patients met that primary endpoint, meaning they decreased their TPN by 20%. And you can see that shown in the light gray bars in the right graph. And that's, to me, very, very interesting. What happened in the placebo? The Tendulotide group we can understand at least that's the effect we were expecting, that's the effect we would have predicted, and we got that. What happened in the placebo group that those patients also decreased their TPN? That's important to understand, and the explanation came from Paley Epperson. It's a little complicated. I'm going to spend a little time on this slide to show you. Just work with me here. So on the right of the slide, you can see the dark blue bar is what happened in the Tendulotide group. That was how much the TPN decreased in the Tendulotide treated patients. And you can see that in those patients, shown in the green bar, this decrease in TPN still resulted in an increase in urine output. And that's a good sign. That's what we want to see, because this means Tendulotide increased intestinal absorption. There was improvement in fluid status. Despite decreasing the TPN, urine output improved. Look at what happened in the placebo group, which is in the left half of this panel. Yes, of course, there was some decrease in TPN requirements in these patients. That's what we saw on the previous slide. But at what cost? In those patients shown in the pink block, what happened was the patients increased their oral intake during the study. They were allowed to up to a certain point. And in that group, in an attempt to decrease TPN, there was really quite an aggressive, likely unconscious increase in oral intake. And much more important, you can see that these changes were paralleled actually by a decrease in urine output, or at least a very modest increase in urine output. Many of the patients actually had a decrease in urine output. So the net benefit, which is called this fluid composite effect, was really very small in the placebo group. Really, when you look at the overall data, close to zero, but in the placebo group, that fluid composite effect, which is a composite of how much TPN, how much urine output, how much oral intake, that fluid composite effect number is much more greater, suggesting a direct effect of Tendulotide on the intestine. This is important to understand. I've often said that the holy grail in the management of patients on TPN with short bowel syndrome is freedom from TPN. That's what we want to see. And what happens in terms of freedom from TPN? We reported in 2017 in JPEN what's called a post-hoc analysis. There were 5 different Tendulotide trials between Europe and the US and some multi-center trials. We pooled all that data together to look at what was the effect in terms of freedom from TPN. And you can see we had about 134 patients, more patients now, who were exposed to Tendulotide. But really only 16 of those patients at that point got freedom from TPN. And I can tell you, if this has not been published, that number has gone up. It's now up to about 21 or 22 patients who are off TPN, which we would expect over time and continued treatment. Patients do come off TPN. But still, it's not 100%, and that's disappointing, but not completely surprising. What is still interesting is that some of these patients have been on TPN for quite a long time, but here's a signal. Many of these patients had colon incontinuity. If you think back to that early figure, these are patients in group 3, a more favorable group. Kwai Lam, who worked with me, reported our single center experience in 2018. At that point, we had treated about 18 patients with Tendulotide. 11 of those patients, so close to 2/3 of those patients, achieved freedom from TPN, and that's a good percentage. But you can see again, 10 of those 11 had colon incontinuity. A recent study from Francisca Joly and colleagues from France in about 54 patients shows somewhat similar data. 25% of patients in their experience achieved freedom from TPN, and it does appear most of those patients had some colon incontinuity, which now clearly appears to be a favorable sign. There are some precautions with Tendulotide use. Before you can get Gattex on prescription, I think these things are important to keep in mind. Tendulotide. GLP-2 is certainly a growth factor, has the potential for acceleration of growth of GI, of polyps in the colon, for example, or if somebody has, God forbid, a cancer that we don't know about, that cancer can grow. So it's recommended, it's essential that patients are treated with GLP to get a colonoscopy before treatment and a year later. There's some risk of intestinal obstruction, especially in high-risk patients who perhaps have a stricture, an area of narrowing from previous surgery. There are some other smaller side effects. By smaller, I don't mean less important, but less frequent. And an important one is fluid overload to talk about. And it's a good example of what's the type of side effect we're worrying about. Fluid overload is really not a toxicity of the drug at all. That's how the drug works. It improves fluid absorption, and if the clinician is not vigilant and cuts back the TPN volume quick enough, in patients who are at risk for cardiac failure, there is some risk of significant fluid overload. There is a requirement to reduce the dose in patients who have severe kidney disease, and we've seen that, and we start those patients on half the drug, half the dose of GLP-2. Finally, I will say that active GI malignancy, if you have any malignancy in the intestine, liver, pancreas, but frankly, in my book, if you've had any active cancer within the last 5 years, that's to me an absolute contraindication to GLP-2, and I would not use GLP-2 in such patients. This slide is very helpful to me. This was shared with me by Professor Oley from Paris. This was based on data presented to the European Medicines Agency in France before the drug was approved. So, Tendulotide, GLP-2, is indicated for the treatment of adult patients with short bowel syndrome-related intestinal failure. It is recommended that this not be used right after surgery. So patients should be somewhat stable following a period of intestinal adaptation. And really, we recommend at least about 6 months after surgery. And the treatment should not be initiated until the patient's stable following a period of intestinal adaptation. We talked about the normal process of adaptation, what is called physiological adaptation. We don't know what is the effect of GLP-2 on that, so we recommend waiting till that adaptation has occurred. And of course, it's critical that the prescription for TPN or IV fluids and nutrition support, attention to diet and oral intake is well optimized before considering initiation of treatment with GLP-2. And then finally, we should be certain that there are no contraindications. I again will emphasize no active cancer. And if these conditions are all met, then it's appropriate to consider this patient for Tendulotide. And I'll tell you, I like the slide partly because this is exactly the algorithm that we follow in our practice before we will start treating somebody with GLP-2. I'm not going to spend a lot of time on the pediatric data. Hopefully somebody else will cover that during this conference. But suffice it to say that really the pediatric data looks very, very similar to the adult data. The pediatric approval came later. There was no placebo group in the pediatric trial for obvious reasons. But really overall, it does appear that both the efficacy of the drug and the safety appear to be very similar in children as it is in adults. So we are learning that there are key differences in short bowel syndrome based on the gastrointestinal anatomy, and this actually appears to influence the response to GLP-2. So look at the panel on the right. These are patients with stomas, and it's roughly 50-50 patients with stomas, patients with colon. And the stoma patients, I told you, are the most challenging to manage. They have high stoma losses. They often need a lot of fluid. They're needing a lot of calories and macronutrients in their TPN. These patients actually have a very robust and rapid response to GLP-2, and there's a robust effect in terms of TPN volume reduction. In contrast, when you look at the colon patients, most of them do fine in terms of fluid. They're having only 1 or 2 stools a day. For them, often they start off very small TPN volumes, just 1.5 liters, whereas the stoma patients may need 3-4 liters of TPN in a day. And in the colon patients, there's a very modest effect of GLP-2 on TPN volume reduction. But this difference in behavior can now inform how we should approach treating these different patients with GLP-2. For the stoma patients, we can try and reduce the TPN volume. We can certainly try and reduce the volume time. We can improve quality of life for sure. These patients are unlikely to wean off TPN completely, but with some effort and with some sort of fudging what we do with the patient, it would be possible to try and get a day or two off TPN. In contrast, for patients with colon incontinuity, majority of these patients can wean off TPN. So for those patients who need GLP-2 and are unable to wean off TPN without the GLP-2, then the goal should clearly be to try and get days off TPN, which is nights off TPN. And the goal actually in my book should be freedom from TPN for these patients. Well, let's look at the crystal ball and see what's coming down the pike. And don't tell me that that guy looks like me. It's not me. So the first of these drugs is glyphoglotide, a novel long-acting GLP-2. This went through a randomized phase 2 trial that was conducted in Professor Yepeson's unit. That data has been reported. And what I can say is in adult patients, this was really a tightly controlled trial in adult patients who received glyphoglotide. Very clearly, there was quite a significant effect on decrease in stoma output that is shown in the bottom left panel, and that translated into an absolute increase in urine output. This was a phase 2 trial. There was no attempt at TPN reduction, but it is this improvement in urine output that we can then translate and try and reduce TPN requirements. So glyphoglotide at all 3 dose levels was safe and well tolerated. In daily doses, that's what was studied in the phase 2 trial, even though it's ideally the real value would be if you can administer it less frequently. In daily doses, glyphoglotide significantly decreased stoma losses and increased intestinal absorption in patients with short bowel syndrome. A multi-center, multinational trial, phase 3, has just been concluded. This was a very difficult trial to run in the height of COVID, you can imagine. There's been early closure of recruitment into the trial, and we await the results with great eagerness. Just to emphasize, the drug is not yet approved. Obviously, that will depend on the results of the phase 3 trial. Upraglutide is another novel GLP-2 analog that has a longer half-life than Tendulotide and therefore provides the expectation that it can be given much less frequently. Interestingly, the right panel, this is now animal data, rat intestine. When rats were given upraglutide, what you can see there, and I think this is an interesting effect, is that upraglutide increased the wet weight of the rat intestine after a single dosing, after a single dose, and after doses given 24 or 48 hours apart, and that was in comparison to Tendulotide and glyphoglotide. So we should see if that translates into any clinical benefit. 2 phase 2 trials of upraglutide have been completed. That data was presented and then published by Johanna Eliasson from Copenhagen, working with Professor Jeppesen. Very well done studies, randomized, crossover, placebo-controlled study, 4 weeks of injection, and then additional treatment with 10 milligrams of upraglutide for 4 weeks. And importantly, This was weekly injection compared to the daily injection of teduglutide. Metabolic balance studies were done, and I'll just say to you that metabolic balance studies are really the gold standard in terms of how to study intestinal failure. It's done in very few units in the world, and perhaps Professor Yepeson's unit is just about the best in this science. And what Johanna was able to show was that there was a significant increase in urine production with upraglutide compared to placebo in the two doses that were studied. And there really was no difference between the two doses, but quite a dramatic difference in terms of mils per day. You can see somewhere between 700 to 800 mils per day of increase in urine output with once a week upraglutide injection. I had the good fortune, actually, Johanna did this work for her PhD in Denmark, and I was her external examiner, and this was really a stellar piece of scientific work. The upraglutide phase 3 study, the STAR study, is currently in progress. I'm quite involved with this trial. I'm the international principal investigator. This is being done over several centers around the world with an ambitious goal of recruiting 144 patients. I'm happy to share that this trial has just has completed the halfway mark. We've just completed more than 72 patients recruited into the trial. And I'll say a shout out to really all of the pharmaceutical companies involved in this area. Zealand Pharmaceuticals for glyphoglotide, Vector Bio for upraglutide, coming down the pike, Hanmi, there's 9 meters. Really a shout out to these companies. These are not easy trials to run. The science is very, very important and helps patients tremendously. So this trial is currently in progress. What is exciting about this trial that drew me in is that for the first time, we are actually trying to study the differences between patients who have stomas and patients who have colon in continuity. The FDA accepted that the data suggests we should do that. And the FDA also accepted that we should be allowed to approach the TPN weaning differently based on that anatomy. And I'm very excited to see, because that's where the science is moving. This slide is courtesy of Professor Jeppesen from Denmark. But before I go into this slide, I do want to really emphasize what is shown in the orange under the title. Beware. These what are called cross-study comparisons are to be taken with extreme caution. This was not data that was meant to compare drugs head to head. But what Professor Jeppesen and I discussed at some length and decided it was important to share, even at this stage, all 3 drugs, teduglutide, glyphoglotide, and upraglutide, went through phase 2 trials really in the same manner, in the same unit. And even though these trials were not designed to compare drugs head to head, what you can see from this data, upper row, teduglutide in the left, glyphoglotide in the middle, upraglutide in green on the right side. When you look at the urine output, there's not much difference. There's a 39% increase in urine output with teduglutide, give or take about 40%. Increase in urine output in glyphoglotide, about 39% in upraglutide increase in urine output. So that looks about the same. When you look at the bottom row, this is very interesting. The increase in energy absorption looks somewhat similar for teduglutide and glyphoglotide. Teduglutide once daily injection, just shy of 800 kilojoules per day improvement in absorption. Glyphoglotide about just shy of about 600 kilojoules per day improvement in absorption. Both teduglutide and glyphoglotide somewhat modest. The energy absorption in upraglutide was significantly higher, just shy of 1100 kilojoules per day. We've not seen this before with other GLP-2 analogs, and this is an effect that I can tell you I'm looking at with some interest. in the upcoming trials. If this is real, this is meaningfully new benefit that might make dramatic differences for some patients. So watch that space. Very quickly in my closing minutes, this is Hanmi Pharmaceuticals from South Korea is working on another GLP-2 analog with a very long half-life that might lend itself to once-a-month injection. They presented this data at Aspen meeting last year, and I'm assisting them in developing a phase 2 trial design. Lastly, how many more GLP-2s do we need? Don't answer that question. So what else is new? This is a proof of concept study from Professor Yepeson's unit. Liraglutide is a GLP-1 analog that was approved for treating diabetes, and Professor Yepeson and his colleagues did a really interesting proof of concept, open label study. And what they showed basically was with GLP-1 injection, ostomy output decreased, and correspondingly, the urine output increased in a small group of patients with short bowel syndrome. But interestingly, look at the increase in energy absorption, which is pretty robust. Clearly, there's a need for larger placebo-controlled trials of GLP-1. And guess what? Coming down the pike is another phase 2 trial called the Vibrant phase 2 program. This is from 9 Meters Biopharma studying Oley2022. I'm not involved in this trial, but look forward to this data with great interest. I'm just shooting past my time. So in my closing slide, I will say to you, freedom from TPN is the goal in intestinal failure care. If we cannot achieve that, we want freedom from complications for our patients. We want to try and achieve a good quality of life. I think we're coming to the era where goals of care can actually be individualized for the patient. Tendulotide can help achieve enteral autonomy. And if we cannot achieve freedom from TPN, we should look to see if we can get nights off TPN. Yes, of course, for some patients, a 20% decrease in volume is meaningful. Is it meaningful in all patients? I ask myself that question sometimes. I will let you answer it for yourself. Finally, novel long-acting growth hormones and GI peptides are in or approaching phase 3 trials. There may be a long-term role in maintenance therapy. And I can't wait for the future. 5-10 years from now, I'm certain and at least very hopeful that we will be looking at combination therapies for patients with short bowel syndrome and intestinal failure. Thank you very much for this opportunity. Be well.